So I'm going to start by giving you an overview of biologics and pain medicine. So PRP, aside from, I guess, prolotherapy is a regenerative therapy. So that's probably one of the most commonly used or oldest techniques. However, in terms of biologics, PRP is probably the most commonly used one, and it's my go-to. It's cheaper than most of the others, and it's also from the patient. So the risk of infection is small. It's not processed in a factory. It's processed right there in your office. And basically what you're doing is you're just concentrating platelets and plasma. And the PRP, well, they do a lot of different things, and they do this through the growth factors release. Platelet-derived growth factor is responsible for angiogenesis, myogenesis, macrophage activation, VEGF, vascular endothelial growth factor, same thing. TGF-beta is for bone regeneration, remodeling, and healing, and regulates the inflammatory process. And extracellular growth factor for proliferation and differentiation. I mentioned bone healing. There are docs doing intraosseous PRP injections. You find the bone defect, you actually stick a needle into that defect, and you inject the PRP or the bone marrow aspirate or the stem cells, and there is regeneration and there's improvement of the patient's pain. There's a lot of stuff in PRP, 7 fundamental proteins. I mentioned a few of them. There's also the fibrin, fibronectin, vitronectin. The platelet-derived growth factor is a glycoprotein. It emerges from the degranulation of the platelets at the site of injury and activates cell membrane receptors on target cells, which in turn develop high-energy phosphate bonds, activating signal proteins to initiate specific activity of target cells. And the activities we mentioned already. So there's a lot of evidence out there. The insurance companies will say there's not enough evidence for PRP. There's plenty of evidence. Are all of the studies good? No. Are all of the studies done in the same way? No. I mean, many of the negative studies, they might be using subtherapeutic PRP. It may only be 2 or 3 times what you get. Every kit is different, and you don't know the platelet count unless you count the platelets. I tend to use one kit, which is very good, and I cannot discuss the name of that during CME time, but afterwards, if you're interested, I'll let you know. There is a lot of controversial studies out there. I've read reports where they're saying insufficient evidence to recommend PRP for rotator cuff tears. If you Google in Scholar rotator cuff tear PRP, there's plenty of supportive studies on this. And you need to do the homework yourself. I mean, I did a lot of the homework for you by presenting these studies today, and you'll see some of them are positive, most of them are positive, some of them are negative. That being said, PRP is probably safer than steroids, and with the exception of the cost, it's really minimal risk. There's a risk of needle entry, infection, bleeding, nerve damage, etc. But for the most part, I'm having a lot of success with PRP. Any side effect with PRP is typically related to the side effect of sticking a needle in someone, vasovagal. Post-injection pain is probably the most common side effect. And it can last a few days to a few weeks. I had one patient where I did epidural and facet PRP. She was a failed back patient. And out of all my patients, she had the biggest exacerbation out of anyone. And typically it's with the disc injections, by the way. The disc is the most painful. But when you're doing PRP epidurally or in the facets, it can be sore, and it varies from patient to patient. It can be nothing, and it can be like a lot of soreness for a few days. You can't mix local anesthetic with your PRP. It will interfere with the platelet function. So for patients like this who they had some sort of exacerbation, a few days later, I would consider trigger points, medial branch blocks, or even an epidural with just lidocaine if the patient is desperate. What are the contraindications to PRP? Well, metastatic disease, any infections in the area, pregnancy or breastfeeding. I don't really have a good answer as to why. I mean, it sounds a lot safer than giving them a steroid or local. Some of these contraindications, I don't know if there's a lot of evidence to support them. I feel most people just abide by this. Nobody's actually doing a big randomized controlled trial on pregnant women, so they're just playing it safe. Remember, you are using an anticoagulant when you're processing PRP. And today I'm going to talk about more than PRP, but 90% of what I do regenerative is PRP, and that goes for most practitioners.